Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board-certified nephrologist and clinical specialist in hypertension. Today's topic, thrombotic microangiopathy. Thrombotic microangiopathy is a condition that is of interest to nephrologists for a couple reasons. First, it is often associated with renal manifestations, specifically acute kidney injury. And second, many of the causes require treatment with plasmapheresis, which is a procedure that is often prescribed and managed by nephrologists. But first, what is thrombotic microangiopathy? Thrombotic microangiopathy is a condition where there are platelet microthrombi in the microcirculation. This leads to a number of manifestations. First of all, thrombocytopenia. This is a consumptive thrombocytopenia due to the platelet activation. Second, microangiopathic hemolytic anemia. This is a mechanical hemolytic anemia caused by shearing mechanical disruption of the red blood cells as they pass through this microthrombi environment. This can lead to third, end organ dysfunction, which is commonly renal, acute kidney injury. Another common end organ dysfunction is neurologic. We're going to get into the different causes, approach to diagnosis and treatment. But before we get into that, make sure you check out bcnephro.com. There you will find articles not only on this subject, but a wide variety of nephrology topics. Also check out the other videos at this channel and Instagram at bcnephro. Since thrombotic microangiopathy is often associated with acute kidney injury, whenever I see a patient with this condition, I take a quick look at the hemoglobin and the platelet count. If there is anemia and thrombocytopenia, we need to find out if there is a microangiopathic process going on. How do we do this? There are two ways. First, look at the LDH. The LDH in this condition typically is elevated, often significantly elevated. And second, look at the peripheral blood smear for schistocytes. When the mechanical hemolysis occurs, there is a characteristic disruption of the red blood cell, which is called schistocytes and can be seen on the peripheral smear. If these are present, then you know there is a microangiopathic process going on, and we need to find out what the underlying cause is. Now, there are three main underlying causes: TTP, thrombotic thrombocytopenic purpura, HUS, hemolytic uremic syndrome, and what I'm going to refer to as secondary thrombotic microangiopathy, which can be caused by a number of systemic conditions and or medications. First, TTP, thrombotic thrombocytopenic purpura. What is this and how does this occur? TTP is a condition where there are large multimers of von Willebrand factor. These large multimers cause platelet activation and cause the platelet microthrombi in the microcirculation, inciting this pathologic process. So why do these large multimers occur? It turns out that normally there is a protein called ADAM-TS13, which cleaves these large multimers into smaller fragments, which don't have this prothrombotic capacity. This is part of the body's counter-regulatory system. In TTP, there is a deficiency in this activity, which can occur either by the development of an inhibitory autoantibody or a congenital hereditary deficiency. Next, moving on to HUS, hemolytic uremic syndrome. In hemolytic uremic syndrome, the primary inciting event is damage to the endothelial cell. Once the endothelial cell is damaged, then the platelet microthrombi develop, causing the clinical manifestations and pathophysiologic process. This can occur typically by two different mechanisms, and therefore HUS is divided into diarrheal Shiga toxin-associated HUS and atypical HUS. In the diarrheal Shiga toxin HUS, there typically is an infection with a bacteria that releases Shiga toxin. This commonly is E. coli 0157 and manifests clinically in most, but not all cases, as a hemorrhagic enterocolitis and therefore presents as bloody diarrhea. This Shiga toxin causes direct endothelial cell damage. In atypical hemolytic uremic syndrome, the endothelial cell damage occurs by a different mechanism. In this condition, there is a problem with regulation of the alternative complement pathway. Now, the alternative complement pathway has constitutive activation, and there are counter-regulatory systems. In this condition, there is either an autoantibody against one of these regulatory factors or a congenital hereditary deficiency in the factors, which leads to unregulated activation of this alternative complement pathway. The complement deposits in the endothelial cells, causes endothelial cell damage, and creates the milieu for the platelet microthrombi to develop. Now, third, there are a number of systemic conditions and medications which can cause a microangiopathic hemolytic anemia and thrombocytopenia, and sometimes the end organ dysfunction. A comprehensive list will be in the article at bcnephro.com, and a link to that will be in the description below, but these include things like pregnancy, malignancy with micrometastasis, infections such as HIV, and medications. Some common medications are the chemotherapy, mitomycin C, gemcitabine, and the VEGF inhibitor, bevacizumab, as well as calcineurin inhibitors, tacrolimus, and quinine. Now we're going to get into an approach to diagnosis and treatment, but before we do that, if you're liking this video, please share it with someone else who you think might be interested in learning about this topic. This helps get the message across and the channel grow. So once we've established there's a microangiopathic process present with the hemolytic anemia associated with an elevated LDH and schistocytes and thrombocytopenia, we're going to look into the diagnosis. Now, the clinical history is going to be helpful here. If there is bloody diarrhea and a hemorrhagic enterocolitis, you're going to think about the diarrheal hemolytic uremic syndrome. And if there's any of the underlying conditions or medications, you're going to think about this. You're going to want to check the coags, PT, PTT, and also probably fibrinogen. The reason for this is DIC, disseminated intravascular coagulation, can cause a similar microangiopathic process. In DIC, the PT, PTT, and fibrinogen are going to be abnormal, whereas in TTP and HUS, they often are normal. The ADAM-TS activity can be sent out, but this takes some time to come back, and treatment is going to have to be initiated prior to receiving the results. Also, the C3, sometimes this is low in a typical HUS. If there is a high suspicion for this, there is a full complement profile that can be sent out, and it's going to take some time to get the results. And also, the E. coli 0157 can be tested for as well. Now, while we're waiting for the diagnosis, we often need to initiate treatment because in many of these cases, specifically TTP, can be fatal if not treated. Now, the mainstay of treatment, specifically in TTP, is going to be plasmapheresis. So this is plasma exchange, typically with FFP, fresh frozen plasma. Now, what this does is removes the inhibitory autoantibody and replaces the ADAM-TS13 that's present in FFP. In TTP, there also is going to be immunosuppression, including steroids, and most often rituximab to inhibit any further autoantibody production. Now, plasmapheresis is often used in other cases as well, with variable degrees of success. In atypical HUS, plasmapheresis can be used, typically has about 50% efficacy, and other treatment for atypical HUS may be needed. The treatment for that, the subsequent treatment that may be needed is something called eculizumab. Now, eculizumab is a C5 complement inhibitor, the pathophysiologic problem of the alternative complement system. In diarrheal HUS, it's more debatable. Plasmapheresis has not been proven to be beneficial, and the care there is often supportive. And a lot of the secondary causes of thrombotic microangiopathy, including post-bone marrow transplant, malignancy, medication, scleroderma, do not respond to plasmapheresis. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. And until next time.